So we're going to take a look at back pain, urinary incontinence, and constipation, and how they intersect and why it's important in the advancement of physical therapy. So these are the objectives. We're going to look at the epidemiology and the intricate connections. We're going to analyze the function of the core, all of the muscles, and all of the systems that work together. And then we're going to look at the biopsychosocial aspects influencing these conditions, and things like stress response, fear avoidance behavior, emotional impact, and the role of pelvic health in the holistic treatment approach. So I have no conflict or financial disclosures to reveal, but I'm open. So if you know any that I can do, let me know. Okay, so this is no surprise to anybody. This is risk factors for pelvic floor dysfunction. And as you can see here, there are many that are very well known to us, and there are many that sometimes are a surprise. The ones that are really well known are things like prostate surgery, pregnancy and childbirth, hysterectomy, pelvic floor injury, increased abdominal pressure, constipation. But what some may not be really aware of is things like obesity and history of back pain as definite risk factors. So epidemiologically, I can't say that word, but I'll try anyway. Overall, according to the World Health Organization, these are statistics from about a year or two ago, 619 million people with low back pain. Leading cause of disability worldwide, low back pain is a major public health issue. I think in physical therapy, we all have identified chronic low back pain as a population health problem. So it's often associated with loss of work productivity. It has high economic burden on the individuals and on societies, and we're not real good about taking care of it. So urinary incontinence affects up to 50% of women, and up to 75% of women over 65 report urine leakage. According to this association, 25 million adult Americans experience temporary or chronic urinary incontinence. It can occur at any age, but it does have a much more common impact over 50. So when we look at the postpartum urinary incontinence, in this systemic review, they found that postpartum incontinence is up to 33%, with twice the risk factor for vaginal delivery versus C-section. And they warn you in this study that this is still very, very, very low reported. And if I remember right, in the ICS, the International Continence Society, they talk about how underreported urinary incontinence is, that there's still a lot of hiding and thinking it's normal and really just, I have to live with it, and really not a lot of people talking about it. How common is back pain in women with gastrointestinal problems? This is a study that many pelvic health therapists understand. In 2008, Maggie Smith and Paul Hodges and group did a huge study in Australia. And it was one of the best logistic regression models of its time, and the results still hold true today. But basically, they cross-matched women by age, by ethnicity, by how they work, and the roles they had in society, and any of the disabilities they had, and really looked at it. And they looked at 38,000 women from 3 age cohorts, excuse me. But basically what it said was, there's a huge association with GI dysfunction and back pain. And in many of these women, the rate of GI dysfunction at one point in their time was up to 87%. Okay, so now we have something that's really walking hand in hand with how much is being reported for chronic low back pain. Some of the things they postulated back in 2008 was that referred pain through viscerosomatic convergence, altered pain perception, and perhaps increased spinal loading with straining during defecation. And then the biggest thing that we're kind of going to tell a little story today is what happens to the abdominal contents and the spine secondary to changes of the intra-abdominal cavity and the abdominal muscles. So it's not just about the abdominal muscles, but this is a key piece of what we're gonna loop together today. And then this is oops, starting to happen. Can you hear me? Are you good? Okay. The worldwide prevalence and burden of functional gastrointestinal disorders. This is the newest results of the Rome Foundation Global Study, which is known as Rome 4. So we're finally there. And this particular Rome 4 is really diving into not just constipation, chronic constipation, but really the gut-brain behavior and the work behind what is, IBS, irritable bowel syndrome. And so you can see that there's more than 40% of persons worldwide who have functional GI disorders. And it's a direct effect of quality of life. And most of the quality of life people that have the worst issues are the ones who have pain. So when you have chronic low back pain, and you have GI disorders, and you've got visceral somatic and visceral crosstalk, you get people who may not have much more of a disease state or dysfunction state, but they have much more of a bother. And that's something really important to understand, because when we see these people with low back pain in the clinic, and we're not asking questions about functional GI disorders, we're doing them a huge disservice. Because if we don't work both sides, we're likely not to have the best outcomes. Then on top of that, what happens if they're having pelvic floor dysfunction in the form of urinary symptoms, whether it be urinary incontinence or frequency urgency or even bladder pain? So we have to consider all of these together as we work forward. In Canada, they did this really cool study in 2017, and they looked at back pain and urinary incontinence. And this has been kind of stuff that's starting to come up in the last 5 years, which is really, really interesting that the research is pointing this way. But what they found was firm evidence to support clinically observed associations between UI and chronic low back pain. They couldn't talk about any type of causation because the research project itself was a survey, so it was a self-reported survey, but the strong association was really important. And in Canada, they have discussed that these findings reinforce the importance of screening these frequently coincident conditions. So I think now we no longer can say, oh, I don't ask those questions. That can't happen anymore. We have real evidence to show that we really, really need to be doing it. Whether you're going to be the end person providing intervention for this situation, doesn't matter. You need to be screening for it in a way that is relevant and a way that is going to be revealing. We had a conversation last night, and I think one of the things that came out of it was, we can't just ask if you've had changes of bowel and bladder. It's on every questionnaire in every clinic, even at my PCP's office. And we have to start asking real questions. Do you strain when you go to the bathroom? Does it hurt when you pass a bowel movement? Do you feel incomplete emptying? Are you bothered by your bowel situation? Do you leak with running, jumping, yelling, screaming, climbing trees? Not, do you have a change in your urinary condition? And the reason why is most people normalize it. Their mothers told them, you had a baby, that's just the way it is. You're in menopause, everybody's got urinary incontinence in menopause. So for most of the public, they still believe it's normal, so they normalize it. So what do they check on the box? No. And what do? We just go on by. So we have to do this. The people in pelvic health physical therapy, you've got to screen the spine. You have to. Low back, we're not going to talk a lot about hips and feet and neck and the stuff in here, but you got to screen the back. And particularly up into the thorax, because all the nerves from the thorax go into the GI system. And T12 through L2 has a lot of differentials that go to the groin, the pelvis, and the hip. So it has to be done. Okay, why does she have pictures of bridges up here? They're kind of pretty pictures. I lived in Pittsburgh for 12 years. But one of the things that, and I never lived where there were bridges, I grew up in the Southwest. So it was interesting because I didn't really know what I was looking at, and I don't have a laser pointer here, but if you can look at the bridge, I'm gonna make a case for the spine and for the visceral system working together here. So just follow the story a little bit. We've got the vertebral bodies that are in the water. Okay, see that part? That's the vertebral bodies. Anchored to the peritoneum and to the intra-abdominal cavity. And then we have the spine, which is the thing that the roads are, and the little cars going up and down the roads are nerve impulses. So the spinal cord is in there. These guys sticking straight up that have things attached to them are the the spinous processes. The things that are linking the spinous processes together, they're like oop and loop and loop. That's the supraspinous ligaments. All right, the multifidus is all the little long lines that are going to the spine. When the multifidus tightens up, it pulls on the supraspinous ligaments. When it pulls on the supraspinous ligaments, it provides stability to the spine and gives turgor so that there's some oomph to the system. So it's not just at the mercy of the waves and at the mercy of the earth's movement, at the mercy of the cars moving on it. And it requires maintenance and times to make it work. Closer picture. It's interesting that man creates structures that reflect our own anatomy. Somebody did a picture of, can't remember the juxtaposition behind it, but it was a picture of nerve impulses that would look what it would look like if it wasn't, that the internet would look like. And based on the stuff that they found in the internet, what people searched for and all of this, and what it ended up shaped like was a brain. Fascinating, right? Well, here we have cortical bone and trabecular bone. See the holes? There's your trabecular bone. See the outer casing? That's your cortical bone. So mimics this. You can see the multifidus has the gears to pull on the supraspinous ligament and give it some oomph and protect the roadway. This is a different bridge that goes over a faster body of water of the Ohio. Thank you. Took me just a second to remember. We've been gone for 3 years. So I was like, what was the river that went through there? Anyway, because of that, there has to be an extra layer of fascia on top of the supraspinous ligaments and the spinous processes to give it a little more oomph. So you can kind of see how we have to build things. This is the long bridge. This is now every time I cross it from Lower Michigan to Upper Michigan, I'm headed home. But this is the bridge that goes over the Straits of Mackinac. It's very long. It has much taller transverse processes, but it's still a suspension bridge. You can still see the same things. You can see the spinous ligaments, supraspinous ligaments, and you can see the long multifidi muscles that are going to control it. And here's a picture of it just going down the bridge. Cortical bone on the side, trabecular bone in between. It's a real grid because this bridge has to move. The wind and the current and the stuff that happens here, if it doesn't move, it would break in two pretty fast. And I love the orange cones because it means osteoblasts and osteoclasts are active. It's always under construction. Always. So, why do I tell the story of the bridge? Because I want to connect the story back to the old version, which is a soda pop can, which is a good valid theory, theoretical model, but I want to bring it a little bit more up to date to what we're really dealing with. So on the left, you see the multifidus muscle, you see the diaphragm, you see the pelvic floor, and you see the transverse abdominis. Those all work together to create some nice intra-abdominal pressure, which supports the spine from the inside of the cavity back. But you've got the multifidus working to increase the turgor of the supraspinous ligaments so that we have some separation of those spinous processes, and we've got some oomph to the system. When this system falls under compression, we don't have that anymore. All right, so we have to kind of screen this out because when we fall under compression here, we have changes in intra-abdominal pressure, we have changes in what the pelvic floor does. The diaphragm cannot work as efficiently anymore, And the diaphragm and the multifidus muscle get inhibited under things of pain and don't work at all. So this is why we have to pay attention to this. On the other side, you're going to see the glottis, which is up at the throat and the higher upper cervical spine. You're going to still see the multifidi, the abdominals, the diaphragm, and the pelvic floor. Now we've raised this thing up to encompass the entire trunk system, which is super important because it doesn't stop at the diaphragm. In fact, what I will try to demonstrate today is that the diaphragm is in fact the linchpin. And we can really, when we look at this, and we're going to look at some models here, I think you'll be able to see how some of this stuff works together and where we can intersect better with chronic low back pain, urinary problems, and GI dysfunction. All right, so if we're going to talk about the diaphragm, we have to talk about breathing. Remember the ABCs of CPR? What's the most important thing? The first one, right? Establish the airway. Without the airway, nothing matters. So game over. So when we think about breathing, we want to think about not only is it a primal activity, but it's the most primal and most important. So when breathing gets affected, everything else gets affected. But with that in mind, think about it, when we can improve breathing, we can actually start to improve everything else. The basis for why we do breath work. Breathing is something that is going to, when it's optimal, the diaphragm and pelvic floor are going to work together. We're going to have the diaphragm coming down, the pelvic floor eccentrically loading. In other words, it's elastic. It's going to stretch, but it's going to stretch with a purpose. It's not just going to go like this and then back up like this. There's that mechanical, elastic recoil kind of connection that goes on. We have to have movement of the chest wall for that to happen. Somewhere along the lines, I can't remember when, I'll date myself, but I think it was back in the 80s, we got this impression that chest breathing was a bad thing to do. And I think it's semantics, because what I'm not talking about is upper respiratory accessory breathing here for flight or fight. I'm talking about normal movement of the ribs, which is bucket handle and pump handle, and 360 degrees around the base of the ribs for the diaphragm to do its job. When we have that, we're going to have the normal movements in the belly as well. And the diaphragm is going to be the governor of what's happening at the pelvic floor. If we decide to hold our breath, our diaphragm halts its activity and becomes static, like an isometric contraction of the diaphragm. When we do that under load, then it's an isometric contraction of the diaphragm with load, right? The only time we want to have that is when we're working beyond the capacity of our musculoskeletal system to do something at the top of it. Otherwise, this system needs to work. And it needs to work together. One doesn't need to work past it or the other, it just needs to work together. Now, if you want to do yoga breathing, and it requires a little more belly excursion, I'm fine with that. That's a particular movement for that particular thing that's going to work the nervous system in a certain way. If you want to do activities where you need a tighter intra-abdominal pressure system, the chest wall needs to have the excursion and the ability to move. Okay, so we need to have both things, but what happens at the diaphragm is really important, because if the diaphragm isn't functioning right, then this whole thing is game over. So, what does the diaphragm do? Well, obviously it helps us breathe. We have negative pressures in the thorax, so air comes in easy, and then we have this lovely elastic stretch, and then we have this recoil and the air comes out passively. Nice tidal line breathing. Then we have forced expiration, where we have to do a little work. Abdominals need to work a little bit more, pelvic floor needs to do a little work, and it's just like any other muscle in the body. It's got to have a stimulus to come back with the right force. So if you think about, if you want to increase strength of the biceps, right? We do a quick stretch to it. That's what happens when they go to lift the weight or they pull on the bands. We need to have the same thing happening here. It's also the primary mover of the abdominal organs. It works as a sump pump. I didn't know what a sump pump was until I moved to Michigan. They have it in Pittsburgh, but we lived on the side of the hill and we never had to worry about it. But in Michigan, there's a water table and the UP is high. Everybody has sump pumps. So the first time I saw it, I was like, that's what that means. Because it doesn't just push the organs back and then just let it come back. It actually sucks them back up. So there's not only just a mechanical piece, but there's a real neurological thing going on here, because each one of those organs has its own motility and mobility. And the diaphragm has to be the primary mover of that. Why? Because we breathe at least 6 to 8 times a minute, and sometimes for people more. So nothing's going to move this stuff more than that. There isn't any exercise on earth because that's going to do that. Because we don't exercise all day long, we go to bed, we sleep, we sit, we do other things. So, and we also have to be able to clear the airway, okay? So we need to be able to cough, we need to be able to sneeze, and we need to do it without blowing our pelvic organs out the other end. So we need to have the right force and the right capacity of the abdominals, pelvic area to be able to do that. We need to get people in positions to also clear their airway. So when people do this, when they sneeze, they drop their chin down, or in our modern society, when we cough, what do we do, right? When we do that, what happens to the airway? It gets cut off. This is something, now I'll date myself again, back in the 80s, I worked very closely with the cardiopulmonary team because I worked in ICU. And the respiratory therapist and I worked very closely together. And how we taught people to breathe the most efficiently as we sat them up. And after they did all of their drainage stuff, and then we did breathing exercises and all of that to keep the pleural moving and all the stuff moving, because these were all people with tuberculosis secondary to AIDS. We grabbed their head from behind, lifted it up and moved it forward so that they could have this natural thing really occur and make it easy for them. That's the kind of breathing that we do when we pant also. So it's not something that we want to do on purpose all the time during the day, but it's something we need to do when it's time to cough and clear the airway. So there's a role for a forward head. It's just, you don't need to live in a forward head position all the time. So when we have faulty breathing patterns, you can see the setup with that. So if we're panting all the time, or we're not getting good diaphragmatic movement, then we're breathing more shallow, we're breathing less efficient, there's more effort to it. That's going to signal the brainstem that something is wrong. The brainstem is going to alert the body and say, we're in danger. Because this goes offline, it can't happen. So you need to pick it up. We need to get a little bit more breath going. We need to get a little bit more excitability of the nervous system. We don't need to worry about oxygenating the gut anymore, because we're trying to run from the tiger or make a decision if we're going to fight. And oftentimes what happens is when people develop these faulty breathing patterns, after they have a big sympathetic response, they don't come all the way back down. They only come down so far. And then this is where they live. And why do we get constipated? Because something is telling our GI system that we don't need it anymore. And it could be as simple as chronic low back pain that has caused the diaphragm to go offline and become a postural control muscle because the multifidus muscle has been inhibited. And the abdominal wall is not working as efficiently as it should because of the feedback it's getting from the chronic low back pain, right? So we're getting that somatic, visceral, and somatic crosstalk in here. So breathing has a lot more to do with low back pain and continence than obesity or lack of physical activity. So you want to know where to start? We know this. Everybody knows this. But this is where it has to become much more intentional, and we have to think about not only do we need to help the breathing, but we need to help optimize the spine so that the diaphragm can do its job better. We need to optimize the GI system and the musculoskeletal system so that the diaphragm can do its job better. Thus, the pelvic floor will be able to be rehabbed, recruited, and brought back into the system better. So, in 2012, they did a study with people with chronic low back pain and people without low back pain. It was a small study, but they laid them flat. So, and they didn't take any pictures of their pelvic floor. Just let's put that out there right now. And what they did was they looked at normal tidal volume. This is MRI pictures of the diaphragm. And people without low back pain had this beautiful movement of their diaphragm, even laying on their back. And it was doing exactly what it was supposed to do. They could measure it and look at it. And then what they did was they had them do resistance. So like you can see in the picture number 2, they had them pick their knee up and they resisted it. They had to pull back against it. And they wanted to see what would happen to the diaphragm. And then they did the same thing with the arm, just the arm coming up and giving them resistance. So they were forcing the diaphragm to work under some, a loaded condition. And what ended up happening was the people with chronic low back pain, my pointer doesn't work, but you can look at it here. This is the tidal volume on the left of the people with low back pain. When you compare it to the people without, this was much smaller. And you can see the ventral part, the part nearest the spine, has pulled up back. And then when you put it under pressure, you can see how much more steeper that part of the diaphragm becomes. And they postulate that under the load with chronic low back pain, the diaphragm is acting as a postural control muscle. And it's doing it while they're laying flat on the back. Which at first I was like, why did they sit them up? But then I kind of get the beauty of it. It's like, wait a second. They shouldn't have to work that hard with their diaphragm if they're laying down. It's kind of like people who are having pelvic floors that they can't move them because they're being held stiff or they're over-recruiting or there's tension in the muscle, even in a laying down position when it's not necessary to be a postural control muscle. So we got to kind of think about that just a little bit more. There's for your reading pleasure, what happened in there. So let's link it up to the abdominal wall and the pelvic floor, just like we did. If we have an over-recruiting tight hurt diaphragm, 2 things are going to happen to the abdominal wall. If there's no pain in the visceral system, the abdominal wall is likely to become a gripper. Because it's got to do something because that diaphragm is pushing down and it's being told to do something. So when it over-recruits, the pelvic floor tends to do one of 2 things. It tends to push up against the load, right? Or it just like, I can't. We've been doing it for 10 years and I just can't do it anymore. So we have this inverse relationship along with a concordant relationship of where the pelvic floor and abdominal wall work together, but then they can also work opposite. And that generally means that we've really fallen into what we call dyssynergic pelvic floor activity, when they need to, they have trouble relaxing to go to the bathroom, or they can't tighten back up against the cough that comes through to hold. And so we have to think about that. We have to think about that in terms of what the diaphragm is doing as well. But we also want to go above the diaphragm and figure out what's happening up here so that we can work the system from the breath, the voice, all the way down to the pelvic floor, and dare I say the feet and everything else too, which brings us into that full integrative approach that we want to look at with chronic low back pain, GI dysfunction, and urinary system problems. This particular study came out in 2022. And what it did is it looked at abdominal pelvic floor activity related to respiratory diaphragmatic activity with and without specific chronic low back pain, okay? Non-specific low back pain. And what they found that people without low back pain, they did this with ultrasound studies, that the thickness and excursion of the diaphragm was good. So that's tidal and forced breathing, right? So they found that that was good. They found the pelvic floor excursion, and they found that it had a great movement and contraction. And they found the thickness of the external oblique, internal oblique, and transverse abdominis. They just had this kind of really nice not one thicker than the other, pulling harder than the other, while they were at rest during this tidal breathing. The ones with low back pain had less thickness in the obturator externus muscle. They also had less excursion of the pelvic diaphragm and less diaphragm thickness with tidal volume breathing, right? And also with inspiration to forced breathing. So just what we saw in Kohler, we're seeing here, and adding the pelvic floor to it. And then we can take the newest stuff that we're learning about abdominal phrenic dyssynergia in patients with functional bloating and distension, which, by the way, is a byproduct of chronic constipation, as we all know, because chronic constipation always ends up leading to this, and then it becomes, for many people, it becomes sensitized, and they get into the whole irritable bowel piece. But one of the things that we've learned, and you can compare it to the Kohler 2012 article, is that what happens is in this study, they took people who did not have symptoms, and they took people with bloating and distension symptoms, and they put a normal colonic gas load in them. Okay, so they put gas into their colon, which is normal. Normal stretch to the lumen, normal things that happen. The people who didn't have symptoms had a response of their abdominal wall to tighten up slightly. And the diaphragm was freed up and could move much easier. Why? That's how we move gas through. That's the normal response to gas in our GI system. It's to gently tighten up and to move the diaphragm to move the gas through, okay? Gives a bit of the intra-abdominal pressure to overcome the intrarectal pressure so we can pass gas, hopefully when it's appropriate. Sometimes we just have to say it's perfectly natural. But in the patients who had the problems, when they introduced gas to them, they had a relaxation, a widening, an increase of the girth. In other words, because the response was allogenic, there was an inhibition of the abdominal wall. And when we have an inhibition of the abdominal wall, what happened was the diaphragm clamps down. Why? We've just lost a postural support system. And now the diaphragm's role is to keep us upright. That's just the way we're wired together. So the diaphragm, if you'll stay with me here, has become the linchpin, right? How do we treat this? Well, I want them to come in when they have gas so that we can work on activities to teach them to actually bring that abdominal wall in a little bit and start working on that 360 diaphragm type of movement. These are not the people I want doing belly breathing. Their bellies are too soft. We want to bring in some stuff. So if you're treating chronic low back pain, and this person has abdominal dyssynergia, because they have gas and bloating and chronic constipation, which we know goes hand in hand with chronic low back pain, we're not going to get the chronic low back pain any better if this isn't taken care of. And it's not just about suck in your abdominals and do a core exercise and 65 sit-ups. That's not going to help it. Make sense? Okay. And there's a picture of it. You can see there's the normal response, and that diaphragm's free to move. And here's the abnormal response, and that diaphragm comes down. And even in this picture, they drew that ventral side closer to the, as the one where the peak is. So it means that it's almost kind of like the diaphragm knows to migrate backwards to protect or to work or hold on to the spine. It's like the extensor muscles of the back. They try to take over when the multifidus goes out or gets inhibited, and all they do is compress. Because they're such long muscles, they're designed for long axial, lengthening for flexion and pulling us up for extension. The same with the long abdominal system. It's designed for pulling us over when we're on the ground, or that kind of thing. It's designed for flexion of the trunk against gravity. They're not designed to hold the, that segmental movement of the vertebrae and that type of control. So we have to be able to treat both sides of the coin and take a look at both sides of the coin. So with intra-abdominal pressure, of course, we're gonna have thoracic stiffness. We're gonna have sleep dysfunctions. We're gonna have probably more of a forward head posture because we're really trying to work against the load that shouldn't be there. When we have constipation, that raises the intra-abdominal pressure. Why? Because you're carrying a poop baby. And then we have to think about what happens is, so the double-edged sword, we're already sensitized because of maybe whatever happened with the low back, but now we're getting sensitized with inflammatory responses from carrying too much stool in our colon all the time. And it's irritating, and it's interfering with digestion, and our system is already telling us to breathe a little heavier and a little harder, or a little different because we're offline, and we've got stress, and now we've got chronic inflammation on top of it. And the person is like beside themselves when they come in to see us. This is why when you treat somebody who has complex conditions like this that are all together, the one thing you want to do is you want to keep it as simple as you possibly can, because everything touches everything. And if we try to go full force on all systems, we're not going to do well. So taking a person like this and putting them in the position of doing just core exercise to help their spine, which isn't a bad thing to do, but it's not going to help the GI system or the urinary system. If we just treat the pelvic floor and get it stronger, we're not doing anything about the bridge on top that's governing the pelvic floor. If we don't get them unconstipated and get them chewing their food and calming down and doing mindfulness activities, then their constipation is going to be a chronic load inside there that's going to keep the pelvic floor in dysfunction. It's going to keep us incontinent. And then we're not going to have any breath or voice to really, move the airway through well. So then we get sick and then it compounds. You can see how this becomes a chronic condition, and particularly with people that are older, because they've been adapting for their whole life until they just can't do it anymore. So we have to help these folks adapt as best as we possibly can. I don't think I need to go through the back, we just did that, but there's all the connections for everybody to just look at again. You can see that everything touches everything. Nothing lives in isolation. Low back pain is not isolated from GI stuff, it's not isolated from the urinary system, and now it's not isolated from the respiratory system, the hormone system, the immune system, and the nervous system. So we have to kind of think about which thread are we going to pull. So one of the things I talked about earlier was thinking about the diaphragm as a linchpin. Where the diaphragm can be acted on really nicely is at that T12 to L2 connection. If you can get people to move there, they can't hold their diaphragms as tight, right? This is the first thing I learned in neurological rehab, that if you want to change movement patterns that are ingrained after a brain injury, whether it be stroke, traumatic brain injury, whatever it is, if you want to help change the muscle response, this is a synergistic response, you use rotation. We can't hold against rotation. PNF was based on this. Everything that we've done in physical therapy is based on this. But particularly here for these patients, it's really important because we want to be able to also affect the peripheral nerves as they come around the side of the abdomen, hypogastric, ilioinguinal, right? All of those ones that give us the groin pain, the hip pain, genitofemoral, they all take off of this area. So does the innervation for the bladder. So does a lot of the innervation for the lower GI. Yes, there's input at L5S1. Of course there is, and there's input from the pudendal nerve area for autonomics. But this is a key one, and we have to pay attention to it, because if we don't treat this, or if we don't intervene, or we don't assess, and we don't look at this, we're not really going to be as effective with the diaphragm as we want to be. There's all those nerves we just talked about. They all come around. Remember, the obturator nerve comes down off of L5S1, and the femoral nerve is up higher. But it's got all those connections that go down in there as well. And then, of course, the pudendal nerve coming off of S2, S3, S4, S5. And then the feet also share a lot of this innervation. So these long tracking nerves, the peripheral ones come around the trunk, but then they feed into the long tracking nerves that go all the way down the legs, the extremities. So we want to definitely do a neuro check on all of our clients. All right, so one final thing to drive it home is the GI system and the urinary system shares neurology from the embryological beginnings. Okay, the foregut, hind gut, all of these things come off of the same buds. And there's a lot of opportunity for visceral crosstalk. So keep that in mind. This is set up from the very beginning. Now, if one system goes funny, the other one's likely to go funny. And when we get into inflammation and the stress piece of it, then more players are being pulled onto the table. If you've ever heard Morgan Mosley talk, he talks about instead of 2 things standing up when the input comes in, 12 things stand up. When they get used to standing up and they start picking on the neighbors, and 24 things stand up. We're not going to draw 24 things down at once. Start where you can, one place, and just start working through the system. So, central sensitivity index, for the people who are still thinking, I don't know. But if you're going to live in the biopsychosocial world, you got to live in the biopsychosocial world. And remember that IBS, cerebral bowel syndrome, you see it down here on the left, right? My left, your right. But you see pelvic pain syndrome, muscle chemical sensitivity, post-traumatic stress disorders, restless leg syndrome, regional pain syndromes, right? Tension headaches, all of this stuff comes together. And then when you really look at that index and you have clients fill it out, you can talk to them about, you know, it's interesting, I saw that you were telling me about your back pain, but you're filling out, you checked off all of these boxes for tension headaches and TMJ and you know, urinary frequency and urgency and IBS. And it's like, well, yeah, I didn't think it was important. But this is why these indexes are so valuable to us, because it helps the client triangulate their information too and stop regionalizing their own body. Because they do that. They come to you for low back pain, they come to you for this, they come to you for that, and they're still going to somebody else over there. And if we could take a look and just bring this complexity into themselves and have it centered into them, then they know that when this gets better, this might start getting better. But they're not independent of each other. So if this stress comes in, this might have been better, but now this is worse, and now this gets worse. They need to kind of be able to see the connections of how they are as a whole body versus as a, I'm gonna put this slide up, and versus a piece and a part. Like, oh, I'm seeing someone for my bowels, and I'm seeing you for my this, and I'm seeing you for this. We wanted to kind of bring it together here a little bit. Paul Hodges did a beautiful article a few years ago with his group. And one of the things that they talked about was something that we've always known, but thank you for bringing it into the physical therapy world in a cleaner picture, I say, with jokingly. This is why I say everything touches everything. One of the statements they made in the paper is that inflammation, stress, and all of these things have a direct correlation with tissue dysfunction, even at the most basic level. But then they said also, given that fact, the good news is that anytime you begin to work on stress and sleep and all of these other things at the lifestyle level, that also impacts the local tissue level, the bigger tissue level, and the other tissue level. So key things, is in here, they can't be ignored. We need to be looking at these people and finding out, how are they sleeping? What is their stress, mood, anxiety, depression? Do they need referrals? What do they need? And how can we begin to start to work with them? Okay. Oh, perfect, thank you. So, just for some fun things, so that we can leave with something like, what do we do? You don't go back and work on the diaphragm, right? If nothing else, if you walk out of this talk with nothing else, go work on the diaphragm, okay? So this is just talking about the effect of chronic changes in intra-abdominal pressures on the long-term performance of the pelvic floor, TA and diaphragm is loss of eccentric control, loss of that ability to load in a lengthened position, all right? So you want to think about that. You can simply take somebody like this and build a better bridge. All we asked her to do, we didn't have to do all kinds of crazy things, it's like, just sway forward on your feet. So there's a reason for the glutes and the lats and the lower abdominal muscles to turn on. And I dare say the pelvic floor, when you lean forward, you get over the urogenital triangle and you can access it easier. Rather than leaning back where the quads are overactive and the upper abdominal is overactive and the glutes aren't working. There's no reason for the glutes to work here. They don't need to hold her up. There's nothing wrong with this person's glutes. It's simply how she's loaded herself up under gravity. Rotation, 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 lumbar spine, thoracic lumbar. I made a big point of that today. The thorax, get the stiffness out. If you can, look at the cervical and craniovertebral, or get them to somebody who can, especially if you're hearing crackly voices, weak voices, and things like that. There's some work that needs to be done there as well. Submaximal and eccentric training of postural and pelvic floor muscles in functional contexts. So that is why it's so important not to just do these exercises or teach somebody to suck their tummy in or pick their pelvic floor up, but to do it in the places where they're having the problem. Work with them with their cough and their sneeze. Work with them with, if they have to leak the minute they step out to run, back them up and work on single leg stance and up and downs and bringing the system together. And can they breathe while they do it? Let's make sure, do we need to build capacity so somebody doesn't hold their breath to get out of a chair? So that we can build up their strength so that their diaphragm can be free to move again and they can breathe as they get up and become continent. So restore rotation, increase changes into extension, restore the link tension relationships of the abdominal wall, restore the functional uses of the abdomen, and stop breath holding. So treat the thorax, treat the diaphragm, and keep people breathing unless they're doing a 1 rep max. Even in the gym, it should not be, if they're breath holding to work, they're working too hard. They work past their ability to do it. Okay, you train the normal coughing and sneezing, and coordination and load transfer. I can't talk more about load transfer is a huge thing, but we have it. So the rest of the slides are just basic things you can look through. They're just talking about thinking about heart rate variability. It's very low in people with IBS. It's very low in people who don't move. It's very low in people with pain. What's the best way to get the heart rate variability up? According to, just flip over here to this latest article, we call it 4x6 breathing. 4 seconds in, 6 seconds out. Start at 2 minutes, work to 5. Do it 5 minutes every day. This article guarantees you in 6 weeks these people are going to be calmer and happier. Pretty simple, right? It has to be paced though. It's got to be guided because our brain will not stay with it. Our brain is designed to wander, so the pacing keeps it going while we're working. And then these are just some other things that hook the mindfulness step up to polyvagal theory. GI, if you can just get people to slow down and chew their food, I kid you not, 40 chews changes their GI function. Plus it also increases their satiety and it increases their calmness and they're just gonna be happier and enjoy their food. So I'll massage, find some joy, do the good stuff, keep it simple. But this is the reason, I hope the story makes sense to you. This is the reason I call the diaphragm the linchpin in that area, the linchpin. You can go into there, you can start to make changes everywhere. Then you can see what comes up and what's important to them. Relevance is key here. Relevance to the client is key.